Hi, this is Michael Altos, and we are recording our next section on blood. This is recording part 6. When blood is collected through blood donation, the whole blood is collected and then a citrate anticoagulant is added. This binds calcium and prevents coagulation while the blood is being processed. The blood is then centrifuged and separated into different components like red blood cells, plasma, platelets, and cryoprecipitate. Another option is apheresis. This is basically an ex vivo centrifugation, where the entire blood is removed from the patient, or from the donor, but only the desired component is removed and the rest is returned back to the donor. Let's start by focusing on red blood cells. In the preparation of red blood cells, there are several options. One common option is called leukoreduction, which means removing the white blood cells from the red blood cells. This can also be done with platelets, removal of white blood cells. Doing this reduces the risk of alloimmunization, which we will talk about later, febrile reactions, and transmission of CMV virus. Leukoreduction may also reduce inflammatory mediator accumulation during storage. It may prevent TRALI, which is the lung injury associated with transfusion, and may decrease postoperative mortality in cardiac surgery. There is a general movement towards 100% leukoreduction of the entire U.S. blood supply. Another method of preparation is called saline washing. This removes any excess plasma in the red blood cells and may help prevent allergic reaction, especially in patients who have IgA deficiency. The washing is not sufficient to prevent graft versus host disease or HLA alloimmunization. Irradiation of red blood cells, that is, exposure of the cells to gamma irradiation, will damage the donor white blood cells' DNA and may help prevent immune response to the recipient's tissues. This might be helpful to prevent graft versus host disease. Red blood cells are also subjected to pathogen detection and inactivation. Nucleic acid testing, like PCR, helps detect pathogens. Inactivation techniques are not commonly used in the United States, but this might include treating the blood products with solvent detergents, methylene blue, or riboflavin. Various additives are then mixed into the blood. The hematocrit of the final product is somewhere between 60 and 75%, with a volume of usually 250 to 350 milliliters. A unit of blood with these additives typically has a shelf life around 40 days when stored at 1 to 6 degrees centigrade in the refrigerator. During this time of storage, metabolic changes occur. The 2,3-DPG becomes depleted, and the oxyhemoglobin curve shifts to the left. Hemolysis and increased potassium levels occur during storage, and by the time blood is administered, 15 to 20% of the red blood cells may be non-viable. It is believed that the age of a unit of blood correlates with adverse outcomes like mortality or organ failure, but the data remains inconclusive. When transfusing red blood cells, 1 unit of cells will typically increase the hematocrit by 3% in a 70-kilogram person. Of course, this assumes that the patient is euvolemic. So let's say someone who has chronic anemia, or acute blood loss in the operating room, but with adequate fluid resuscitation. Ultimately, transfusion therapy should be guided by regular measurement of hemoglobin or hematocrit, bearing in mind that levels may be artificially normal or even elevated before fluid resuscitation. We would call this a patient who's hemoconcentrated. At what threshold should we transfuse blood? Well, this is an area of ongoing active research and debate. The ASA says that red blood cell transfusion is rarely indicated if the hemoglobin is greater than 10, and almost always indicated when it is less than 6 grams per deciliter. Several studies in critically ill and post-cardiac patients have shown no difference in outcomes between liberal and conservative transfusion guidelines, say 10 versus 7 grams per deciliter, or hematocrits of 24 versus 30. And in fact, transfusion may be an independent risk factor for morbidity and mortality. So we do want to avoid transfusions if they aren't truly necessary. Patients who have cerebrovascular disease or neurologic injury have worse outcomes when hemoglobin falls below 9 grams per deciliter. But it's very unclear if giving red blood cells by transfusion will improve their outcome or may worsen their outcomes. In general, the current data support the following thresholds. In asymptomatic ICU patients, a threshold of 7. Patients with acute coronary syndrome, a slightly higher threshold of 8 to 9. Patients with neurologic injury, typically 7 to 9, perhaps closer to 9 in patients who have ischemic injury. And for all other patients, the threshold remains widely between 6 and 10 grams per deciliter. Remember, the goal of transfusion is oxygen delivery. We want to keep oxygen supply greater than demand, and red blood cell transfusion gives us hemoglobin, which can transport oxygen. We can also try to limit demand in patients who have hyperthermia, hyperthyroid, sepsis, or pregnancy. And we can try to maximize supply. Supply could be limited in patients whose cardiac output is diminished due to coronary disease, sepsis, or heart failure, as well as patients who have alkalosis, hypothermia, hemoglobinopathies, pulmonary disease, or hemorrhage. Clinical signs of tissue hypoxia, which might suggest that we should transfuse the patient in order to increase oxygen delivery. These might include changes in vital signs like tachycardia, hypotension, tachypnea, or dyspnea, lab or monitor value changes such as decreased mixed SVO2 or central SVO2, decreased oxygen extraction or lactic acidosis, and end organ dysfunction, including ECG changes, EEG signs of hypoperfusion, or acute oliguria. The body has many physiologic responses to anemia. The first response is to increase cardiac output. Remember, cardiac output is stroke volume times heart rate, or mean arterial pressure divided by SVR. So the body could increase heart rate and stroke volume, and it may do this as a result of the decrease in SVR, which occurs as a result of low viscosity as we lose red cell volume. Cardiac output can actually autoregulate over a wide range of isovolemic hemodilution in order to maintain adequate cardiac output. But cardiac output will be impaired in patients with acute blood loss because of the vasoconstrictive response in order to maintain blood pressure. In addition to increasing cardiac output, the body can also redistribute cardiac output to those tissues that need it most. So the brain and the heart will get more cardiac output at the expense of the muscles, skin, and viscera. Coronary blood flow can be increased by as much as 500%, but as we'll see in a moment, extraction cannot be improved in those tissues. We do see patients with reversible cognitive impairment when hemoglobin drops below 7. Oxygen extraction ratios can increase from a baseline of 38% to about 60% as the SVO2 drops from 70 to less than 50%. One exception is the heart, which already has an extraction ratio of 55 to 70% at baseline and really cannot improve in cases of anemia. The affinity of the oxygen-hemoglobin binding also can change. As hemoglobin drops below 9 grams per deciliter, the curve will shift to the right over about 12 to 24 hours, and this is due to 2,3-DPG as well as acidosis. This increase in the P50 will improve oxygen release to tissues. Bear in mind, however, that stored red blood cells have depleted 2,3-DPG. Finally, the microcirculatory blood flow can alter. We see this mostly in chronic anemia. As blood becomes less viscous due to decreased red cell volume, there will be improved microcirculatory blood flow through those tiny vessels. There will be release of nitric oxide, which causes vasodilation, increases preload, and improves venous return. And it will also increase angiogenesis in order to further improve oxygen delivery to tissues. We'll stop here. As always, please let me know if you have questions, and we'll continue in the next recording.